Good morning, everyone. Thank you all so much for being here today. I'm going to go ahead and wait just a couple minutes so that some more folks can trickle in, and we'll get started in just a few. Okay, it looks like we have a pretty good crowd, so I am going to go ahead and share my screen so we can begin. So good morning, everyone. Thank you all so much for being here today. My name is Eliza Davern, and I am the office manager at Lawyers for Civil Rights. At Lawyers for Civil Rights, we tackle a wide range of social and racial justice issues, including issues surrounding healthcare and housing disparities. I am very excited to present my work titled Detangling Dobbs, which I believe provides very relevant and vitally important coverage of some of the most pressing issues that we are seeing today in women's healthcare. If anyone has any questions or comments, I will be leaving time at the end to address those so that we can all have a good discussion. Before we begin, I just want to flag that this presentation does discuss realities around abortion and sexual assault that may be uncomfortable or triggering for some folks. So I have included a trigger warning in the upper right-hand corner of some of the slides. If at any point you would like to mute the presentation or step away, please feel free to do so. And I will do my best to alert the audience when those moments arise. So this lecture is titled Detangling Dobbs, the intersectionality between housing instability and reproductive rights. Both are hot button issues, but they are rarely discussed in the same context, which is ironic because experiencing one makes one person much more susceptible to the other. If someone is experiencing housing instability and they do not have access to abortion care, that will certainly intensify their situation, and vice versa. If someone is expecting an unintended pregnancy and they do not have access to abortion services, they are more likely to fall into housing stability. So that's what we'll be discussing today. So the overturning of Roe v. Wade unravels nearly 50 years of constitutional protections and devolves the power to regulate reproductive health to the states. This lecture seeks to explore and critique the impact of the Dobbs decision within this context of housing insecurity. So people experiencing homelessness and housing instability have worse reproductive health outcomes, as access to stable housing has been identified as one of the most important predictors of one's health. These health and housing disparities are only compounded by the radical rollback of abortion rights. So the objectives of these lectures are to, one, uncover the relationship between housing and abortion care accessibility. Two, to understand the implications of the Dobbs decision in this context. And three, to offer suggestions to aid women and mothers who remain the most vulnerable. So what does abortion have to do with housing? Issues surrounding homelessness and abortion are, as I said, rarely discussed in the same context, even though they intersect in many ways. So people who seek but are denied abortions are up to 3 times more likely to fall into poverty than people who are able to obtain abortion health care. People experiencing homelessness and poverty are already experiencing higher rates of unplanned pregnancies and already have disparate access to comprehensive sex education and birth control, and they're less likely to have access to health insurance. So women experiencing homelessness are less likely to receive adequate prenatal care than housed women, and this leads to much worse pregnancy outcomes in the long run. So according to the National Healthcare for Homeless Council, the impacts of the Dobbs decision have very real consequences for the health and the well-being of those who are experiencing homelessness. To start off, homeless people have more difficulty accessing contraception that would prevent pregnancy in the first place. Continuing with an unintended pregnancy while experiencing homelessness adds significant trauma and stress to a situation that is already a crisis. Factors such as lack of paid parental leave, unaffordable childcare, a lack of a social safety net makes it more difficult to retain employment and thereby places a significant economic burden on those who are already most vulnerable and becoming mothers. Violent attacks on people who are homeless are unfortunately shockingly common, and unwanted pregnancies resulting from sexual assault and rape are especially traumatic. There's a constant fear of engaging in the child welfare system and the subsequent loss of child custody due to homelessness status. And lastly, the overwhelming loss of self-determination that is already inherent in homeless people is already compounded by having to continue on in an unintended pregnancy. So all of these factors and more, these are just some of the things that make it harder for people to engage in care that they need and regain housing stability. So let's take a step back and discuss what the realities of abortion look like in the United States and what trends we're seeing among people who need abortions. So most people in the US who have abortions are actually already parents. The typical patient, in addition to already having children, is low income, is unmarried, typically in her late 20s with some college education, and it's typically a patient who is very early on in their pregnancy. But in the reproductive lives of women, and I would like to say when I use the term women in this presentation, I'm using it as an umbrella term, referring also to transgender and non-binary people who can also become pregnant. So in the reproductive lives of women across America, abortion is not uncommon. In the latest estimate from the Guttmacher Institute, which is a reproductive healthcare research group that supports abortion rights, they found that 25% of women will have an abortion by the end of their childbearing years. So that means 1 in 4 women will have an abortion in their lifetime. It's important to look back even further to fully understand the origin of abortion policy. I don't know if you can see, but there is a little trigger warning on the side of the slide. Abortion has been around long before the United States government, and medical literature and newspaper from the 1700s and 1800s actually regularly referred to herbs and different medication as abortion-inducing methods. So this was a very common practice. Outlawing abortion only became a cause among US politicians in the late 1800s, and bans then followed, with abortion becoming illegal in all states by 1910. So women who couldn't afford to pay the few providers offering abortion or who felt afraid of criminal charges oftentimes tried dangerous methods of self-managing abortion. So in desperation, women would insert themselves with knitting needles or coat hangers. They used solutions such as lye or ingested strong drugs or chemicals. Because many of these deaths were not attributed to unsafe or illegal abortion, it's impossible to know the exact number of lives that were lost. However, hospitals had entire wards that became dedicated to caring for women suffering from health complications, most of whom who had tried to induce their own abortion or had an illegal abortion procedure. In 1939, Cook County Hospital, Chicago's public hospital, reported treating more than 1,000 women annually, 1,000 women every single year related to wounds from self-managed abortions. And that number jumped and increased to 5,000 women per year by 1962. So just to fully grasp the gravity of this pre-Roe era, I want to share a passage that was written by Alan Wieland, who is a retired OB/GYN physician who practiced in Portland, Oregon, and he recounts his time working at Cook County Hospital before abortion was made illegal. So this is a passage. Abortion was still illegal, and women who were pregnant and desperate would seek ways to end their pregnancies. Those with resources could find ways to safely terminate a pregnancy, but others, including those the most poor minority communities served by our hospital, did not have that option. They instead turned to methods including self-medicating with a number of toxic chemicals, attempting to introduce something into the uterus, and seeking someone willing to perform an illegal procedure. These methods often had disastrous consequences for the women involved, consequences that we saw firsthand when they were brought into our hospital. A section near the emergency room was set aside for triage of these patients. I saw chemical burns as well as perforations of the bladder, vagina, uterus, and rectum. Some women came in with overwhelming infections or in septic shock. The role of triage was to determine who needed immediate surgery and who could go to the ward. At the time, Cook County had a 40-bed septic abortion ward. It was a large room with beds separated by curtains. And when the patients died, I was called to the morgue attendant to collect their bodies. A death in this ward was a common occurrence. 1 year later, Roe v. Wade was decided and abortion was made legal. Within a year or so, the septic abortion ward at Cook County Hospital closed as it was no longer needed. So I think that this passage really encapsulates what a pre-Roe v. Wade world looked like for those 25% of women who are seeking abortions. So moving along, the Supreme Court's ruling in Roe v. Wade on January 22nd, 1973, decriminalized abortion nationwide and protected the right to access abortion legally all across the country and freed many patients to access the care they needed when they needed it without fear. Unfortunately, on June 24th, 2022, the Supreme Court ruled in Dobbs v. Jackson, a case involving a challenge to a Mississippi ban on abortion at 15 weeks pregnancy. And this ruling overturned Roe, which ended the federal constitutional right to abortion in the United States. So as a result, 1 in 3 women now live in a state where abortion is not accessible. And something to think about, right? 1 in 4 women will need an abortion. 1 in 3 live in a state where they cannot access it. In the first few months after Roe was overturned, 18 states banned or severely restricted abortion. And today, more states are working to pass the bans that are similar. The abortion bans that have taken effect since June of 2022 have inflicted harm on Black, Latino, Indigenous, and other communities of color, communities where systemic and racism has long blocked the opportunity for healthcare. I've included an image here of the Turnaway study, which is the largest study to examine women's experiences with abortion and unwanted pregnancy in the United States. The Turnaway study was turned into a novel, and it found serious consequences of being denied a wanted abortion on women's health and well-being. So women who were denied an abortion and who had to carry their unwanted pregnancy to term had 4 times greater odds of living below the federal poverty level. In addition, women who are denied abortion are more likely to experience serious complications from the end of their pregnancy, including preeclampsia and death. They are more likely to stay tethered to their abusive partners. They are more likely to suffer from anxiety or loss of self-esteem in the short term of being denied an abortion. They are less likely to have aspirational life plans. They are more likely to experience poor physical health for the years after their pregnancy. And the study also finds that being denied an abortion has serious implications for the children that are being born into these unwanted pregnancies, as well as the existing children in the family. And this last image here is a graph from the Gumatcher Institute, just reiterating that these issues are heavily concentrated in low income and BIPOC communities, which is really important to keep in mind. So now turning to homelessness. On any given day, more than 560,000 people experience homelessness in the United States. Additionally, nearly 11 million households are severely cost burdened, meaning that they spend nearly half of their income on their housing and could be on the brink of homelessness. Now, this is important because, as we discussed earlier, having to follow through with an unintended pregnancy creates a severe cost burden on mothers and families in this situation. So if 11 million families are on the brink of homelessness and do not have access to abortion care, they are falling into a financial crisis and they are more likely to experience homelessness. It's very important to note that compared to white people, Black, Indigenous, and other BIPOC communities are even more likely to be homeless. Gender also heavily influences housing access, housing stability, and housing opportunity, yet most of the housing justice data legislation disregards misogyny and gender discrimination as a contributing factor. So the point here is that women in the United States, especially women who identify as BIPOC, face additional hurdles when trying to find and secure housing. So the multifaceted reasons people, and particularly women, experience homelessness are systemic and structural. They include, but are not limited to, a nationwide lack of affordable housing, a history and a current practice of racist governmental policies such as redlining and blocking BIPOC families from affordable housing programs, and ignoring the needs of underserved communities, such as formerly incarcerated people, survivors of domestic violence, and LGBTQ youth. It's also important to know that the economic upheaval and explosion in unemployment from the COVID-19 pandemic has increased this risk of homelessness. If the relationship between unemployment and homelessness continues the way that it has, there could be a 40 to 45% increase in homelessness this year, which means an additional 250,000 people could become homeless because of the COVID and unemployment trends that we've been seeing. So disparities in who experiences homelessness exacerbate the already large maternal and infant health equities that plague BIPOC families. Unfortunately, The full impact of homelessness on moms and babies is unclear because of the lack of disaggregated stratified data available by subgroup. But nevertheless, there's evidence that shows that compared to white people, BIPOC communities are more likely to experience homelessness. Pregnant people experiencing homelessness are disproportionately Black, Latino, and younger. So Hispanic and Latino people are twice as likely to experience homelessness, and Black folks are 5 times more likely to experience homelessness compared to their white counterparts. So homeless women experience disproportionately high levels of sexual violence before and during homelessness. I'd like to note, I don't know if folks can see it, there is a trigger warning on this slide. Homelessness vastly increases a woman's risk of being sexually victimized. Barriers to services often prevent homeless sexual assault victims from accessing assistance after a crime. Homeless women are particularly vulnerable to multiple forms of victimization, including being forced, coerced, or manipulated into sexual activity. Homeless women experience disproportionately high levels of sexual violence, which was found in a 2009 study. In this study, nearly 80% of homeless women had been subject to rape, physical assault, and/or stalking at some point in their lifetimes. That same study found that respondents who were physically or sexually victimized were homeless a greater number of times and spent more years compared to other respondents who had not reported victimizations being homeless. So these physical and sexual attacks and these violent attacks on women have a serious impact on their ability to move forward. Experiencing homelessness is a huge risk factor for being the victim of a sexual assault or a rape, and puts the individual in the position of needing an abortion. So as we have established, access to stable housing has been identified as one of the most important predictors of one's health. People facing housing instability or who have fallen into homelessness have less access to healthcare. People facing housing instability or have fallen into homelessness are more likely to need the pressing healthcare that pregnant people require at this time. During a pregnancy, it's a time when people need access to high quality and affordable healthcare. It's crucial. So pregnant and parenting people experiencing homelessness face barriers such as a lack of transportation or discrimination from healthcare providers, or the inability to figure out or know where to go or how to find insurance or how to find coverage. I mean, for some people, all of these obstacles bar them from accessing care altogether, right? Additionally, people experiencing housing instability or homelessness are more likely to live in conditions that are hazardous to their health, and in turn, hazardous to the health of the family and to the infant. So the evidence here is clear. People experiencing homelessness produces worse health outcomes for both pregnant people and the infants. So we know people experiencing homelessness and housing instability have worse reproductive health experiences, but what does that mean? That means that they have a higher likelihood of a poor pregnancy outcome. This could be a preterm birth, a low birth weight infant, a longer infant stay in the hospital, anything like that. And researchers found that nearly 20% of abortions in the US were found to be among people experiencing homelessness or housing instability, while people experiencing homelessness only make up less than 1% of our population. So when compared to those with stable housing, these folks were later on in their pregnancies when they had their abortions, and they had more abortion complications. So we identified earlier that one of the common characteristics of someone seeking an abortion is that they're relatively young. Pregnancy rates among youths experiencing homelessness are much higher than those of their housed peers. There's limited research that exists on this population's abortion experiences, but I was able to find a study that examined abortion attitude, experiences, and decision-making through 30 individual interviews of youths aged 18 to 21. And this was their experiences. So respondents indicated that abortions are common among this population. Many of the youths also reported that they either had or knew of others who had attempted their own abortion outside of the formal medical system while experiencing homelessness. Most of the youth also noted that self-inductions resulted from not knowing where or how to access abortion safely. Many feared stigma, many feared judgment, and many feared violence from family members or serious partners as a response to obtaining an abortion. The study also found that most youth reflected inaccurate perceptions regarding abortion cost, accessibility, and legality, which ties back to what we were just talking about. There's a lot of unknown, there's a lot of fear, there's a lot of stigma, and there's a lot of barriers already in place, never mind the complete inaccess. And then, according to the American Public Health Association, people who seek but are denied abortions are again up to 3 times more likely to fall into poverty than people who are able to obtain that abortion health care. So this data really speaks to the gaps in our healthcare system and the need that women suffering from homelessness have for proper health education and health policy. People experiencing homelessness and poverty already have higher rates of unplanned pregnancy. They already have disparate access to comprehensive sex education and birth control. They have less access to health insurance. So there's a big need here that is not being met by the systems in place. So I wanted to share a passage. A few years ago, the Boston Globe did a piece on a local woman who gave birth while battling the realities of homelessness. And I wanted to share a piece of this to sort of paint a picture of what this issue really comes down to for the victims. I know I've been throwing around a lot of statistics and percentages and numbers, but this is a very real issue. And for someone who is in this position, it's very raw. And so again, a bit of a trigger warning, but I wanted to share this passage that the Boston Globe wrote about in 2018. On the day after Thanksgiving, Marie lay for hours under her blankets, trying to ignore the pain in her belly. Forget, she told herself. Her dead father, her boyfriend in jail, her homelessness, the bottomless need, and the things that she had done to feed it. The bitter cold and the baby, and her stomach. The pressure was intense. She rose and realized she could barely move. She squatted on the loading dock. She searched down, felt something hot and slippery. After that, her memory splinters. Marie does not know when the baby stopped breathing. She knows he was born with a single push. She knows she shouted for her friend sleeping nearby to please call 911, and that her friend gave her a yellow fleece blanket to wrap the baby in. She knows she heard him cry, but she does not remember the moment when he went into cardiac arrest. She does not remember the ambulance arriving or that she sat on the loading dock screaming while EMTs performed CPR on his small little body. And she does not remember the moment that he came back, tenacious, improbable, insistent on life, because by then, other hands were holding him. The EMTs brought Marie and the baby to Tufts Medical Center. The drugs she had taken coursed through his body. She said he went into withdrawal. He weighed a little more than 5 pounds. Marie held him just once at the hospital. The state had taken custody immediately. She said, "He's not mine." They lay in silence, breathing in and out. She gave him her father's name. She had nothing else to give. And then she was gone, back onto the street, trying to forget. So I wanted to share this with you, not to jerk at tears, but because we've been talking about, health complications and taking a pregnancy to term. And that might sound a certain way when you talk about it, but the reality of it is very, very different. This is life-changing, the life of the mother, the life of the baby, the life of the family. This is why we need healthcare systems to be able to serve the people who are most vulnerable. And we're not seeing that. So with the overturning of Roe v. Wade, access to abortions will become even more tenuous. As the states restrict abortion access or ban them completely, individuals are left with few other choices, as we've discussed. For people seeking abortions, this process will be taxing. But for people experiencing the most severe socioeconomic disadvantages, this expectation is fully unreasonable. Moreover, people seeking abortions might even attempt to complete the process independent from medical providers or without medically approved methods, which can be fatal to those who attempt them and, of course, to the child involved. The rights to healthcare and housing are interdependent, and in the absence of other remedial steps, the decision in Dobbs will result in increased housing instability and increased levels of homelessness. There will also be dire consequences for the most vulnerable Americans. And criminalizing access to reproductive health care is a clear violation of basic human rights. So we don't want to end things on that note. There are things that we can all do individually and collectively as a society, but I wanted to offer some recommendations for things that we can all do today. So the first is donate your time, donate your money, consider supporting a local or national organization. Planned Parenthood is one of them. LCR Health Justice is one of them that supports women in your community. Another great thing we can do is vote, exercise your constitutional rights, vote for politicians and policies that prioritize women's health and access to abortion. And the third thing we are all already doing today, right? Educate yourself and educate people around you about the realities of women's health and the importance of abortion access. This is not just a woman's issue. And by speaking up and sharing topics that might not be the most comfortable to talk about, people are really making a big difference. And so don't shy away from those conversations. So donate, vote, educate, and keep the conversation going. I wanted to share some of my work cited and offer it up for questions. So if folks have any questions, you can feel free to take advantage of the chat and we can answer questions that way. Or if you want to raise a hand and unmute, I'm happy to have a discussion. Okay, I got one question that says, can you tell us a bit about health justice? And then I'll go to the next question. Yes, at Lawyers for Civil Rights, we have had a long-standing medical legal partnership that serves the whole person, not just their medical needs, because as we know, there are many legal needs that tie into and intersect with people's health problems. So last year we revamped and rebranded this program and it became our health justice program. And we are serving low income and minority women all across the greater Boston area, helping them with immigration services, helping them with hate crime services. helping make sure that they are not a forgotten population, because as we've seen in many ways, women often slip through the cracks. So if you want to learn more about LCR Health Justice, you can visit our website, lawyersforcivilrights.org/health justice. It looks like Christina raised a hand. If you want to unmute, I'm happy to answer your question.
Hi, I am with South Coast Fair Housing, and I'm wondering if you have any suggestions for how, as like fair housing advocates, right, like we may be able to sort of message the connection between reproductive rights and fair housing or housing instability.
Absolutely. Thank you so much for joining, and thank you so much for your question. I think what I've come across in my research is that a big gap is shelters. Shelters are a area where people go to in crisis. And because things are moving very quickly and people are trying to help as many folks as they can, sometimes these greater issues slip through the cracks. So I think that a great place to start would be going to these shelters that serve these populations and asking, what are you seeing and what can we do and how can we intervene to advocate for this population that is oftentimes very much voiceless. And I think, as I said, participating in discussions and important conversations like today is always a great start, and to just keep that conversation going with the right people. Somebody put a question in the Q&A. What is more effective, taking care of abortion rights first or housing availability? Can both be tackled at the same time? That is a great question. I think that right now, as we've discussed, all of these issues are really intersecting. So it's important when you go to the polls to be voting for people who have the best interests in mind for the most vulnerable populations, and to be keeping in mind when reviewing policies or making decisions, not to just think about ourselves, but to think about the needs of others. So I would say that right now, I think, as I mentioned in the beginning, they're both very hot button issues of housing instability or lack of housing completely, and access to abortion. I do think that addressing the abortion issue is an urgent need because of the decision that was just made last year. That was a very radical decision and a very radical rollback of protections that we had previously seen in place. So I think most immediately we need to do away with that and go back to the system that we know is what women in this country need. And I would hope that at the same time, we can work towards creating more affordable housing and creating more opportunities for women to be able to secure the housing that they need. So I hope I'm not dancing around the question too much. I think both are very, very urgent issues at hand, and both can be addressed in different ways. Thank you for your question.
Eliza, there's another question in the chat. It says, great job, Eliza. As a healthcare worker, this discussion is so vital to the Boston community and women especially. How can we as healthcare providers continue to support LCR in the greater Boston community?
That is a really great question. Thank you so much. As I've already said, our health justice program at Lawyers for Civil Rights is a really robust program that is constantly expanding to meet the needs of women in our community. So staying apprised of the work that we do and volunteering, as I said, your time or anything is always super useful. I always think that it's important for healthcare workers to be acknowledged. They are incredibly helpful and needed in our communities, and they already do a lot of great work. Again, I think one of the major issues is certain people slipping through the cracks. So if somebody walks in and they are there for a certain checkup or a certain procedure or a headache or whatever, one thing that LCR Health Justice does is looking at the whole patient and all of their needs. If they are experiencing breathing problems, is it due to maybe mold in the house? Does the landlord need to have a call with somebody? And just thinking strategically and critically through different ways that we can assist someone outside of the typical healthcare protocols that are in place. So I think looking at the patient and the person as a whole is really, really important. To make sure that we bridge those gaps that we've discussed and that people get the care that they really need for long-term health equity. But again, healthcare workers already do a really amazing job, especially in Boston. So thank you so much for your work, and thank you so much for your question. I can hang on for a bit in case folks have more questions. But if not, I'm happy to give you a little bit of your day back. It's a beautiful day. I hope everybody around is able to enjoy. If anyone has any further questions, oh, here we go. This says, thinking of people who are likely to fall through the cracks. Yep. As well as the stories shared from the Globe of the woman who had her child taken away. Can you speak to the role of harm reduction? Can you speak to what role harm reduction can play in both the fight against housing instability and reproductive justice? That's a really, really great question. I think that harm reduction is something that should always be on the forefront of our minds and is often not, especially in these situations that are very crisis-like. You want to make sure again that you're looking at the person as a whole person and the patient as a whole patient. And I hope that the story in the Globe, Marie was a surname that was used to protect the woman's identity. But I would hope that in that situation, Marie was not treated just like a homeless person, that she was treated like a mother. And I think that keeping in mind people's whole identities and their backgrounds and their history is just really important, and keeping a strong sense of humanity in all of the work that we do. When you work in healthcare, when you work in social justice, is just always vitally important. So I hope that that's a helpful answer. I think harm reduction can play a huge role in both fights and should always be something that people are mindful of. Okay, I'm going to go ahead and put my information in the chat so that if folks have questions that arise later, please feel more than welcome to email me, and I'm happy to have a more in-depth discussion. And thank you all so much for joining. I really, really appreciate it. And it was really great to connect with everybody here. Thanks, everybody.
Eliza, this is Rhonda. That was, I had, I work in civil rights and I hadn't heard a discussion before the intersectionality between the two. And I am a very proud person who donates and spends time with Planned Parenthood, having used it when I was much younger for healthcare. So I could check off all those boxes, but your presentation was really great on the spot for the times. I wish there was more I could do. So thank you.
Oh, thank you so much. That's super, super meaningful. And thank you so much for the work that you do with Planned Parenthood. They really are a fantastic and robust organization. They do great work with abortion services and outside of abortion services. Amazing,
Yes.
amazing work for the woman as a whole, right?
Absolutely.
So thank you so much for sharing, and thank you for the work that you do. I'm really happy you were here today.
All right, so I suppose I'll stop recording.
All right. Thank you so much, everybody.
Thank you, Eliza.